So we've just finished auscultating the 4 quadrants of the abdomen. We are going to, as I said, auscultate the vasculature, primarily the descending abdominal aorta, but I want to cover that as part of the vascular exam. So sticking with the gastrointestinal portion, we're going to move on to percussion. The purpose of percussion is, as the abdomen is a black box, we're trying to get the size and location of the organs that are under our fingertips. The most important thing when, actually anytime you're laying hands on a patient, is to visualize the anatomy that lies beneath your fingertips. So if you can remember what you're supposed to be over, that'll give you an idea of, okay, what am I feeling? What does that mean? When you're thinking about abdominal organs, again, besides size and location, you're also trying to determine their density, if they're filled with fluid or air, or if they're solid. That's what you're trying to determine by percussion. Now, 2 people should not ever be percussed. People who have abdominal aortic aneurysms and people who have had transplants anywhere in their abdomen should never undergo percussion, just to be on the safe side. Remembering the 4 quadrants, that's where you're going to do your percussion. Thinking about what's in those 4 quadrants, the right upper quadrant should be primarily the liver. So as you're percussing, if you're percussing over an organ, you're going to get a dull response. If you're percussing over air, it should be tympanic, much like hitting a drum. So just thinking about this for the liver, we're not going to go over to these quadrants right now, but thinking about the right upper quadrant, the liver lies essentially on the middle of the costal margin, that vertical line. So you come here and you want to go down vertically, and you're listening for when the sound changes from dull to tympanic. And when it does, that's the lower margin of the liver. And you're going to sort of want to measure how far below the ribs that is. Now, there's a wide variety of size of livers, so I would not be too concerned if your patient is 2 fingers or even 3 fingers. But if you're down here at the level of the umbilicus and you're still getting a dull sound, that's probably not such a good idea. So that, like I said, the normal span of the liver, it's about 6 to 12 centimeters in that mid-clavicular or the mid-costal margin line, and about 3 to 6 of those centimeters is below the costal margin. Again, thinking about what's in every quadrant, let's just run through it. Right upper quadrant, primarily the liver. You're not going to really be able to palpate or percuss the gallbladder. You're also going to have some of the ascending and transverse colon. Moving to the right lower quadrant, the big deal is the appendix, the cecum. You also have some portions of the ascending colon. In the left upper quadrant, you might get some of the liver. You may or may not. The stomach, the pancreas, portions of the transverse and descending colon, and then finally in the left lower quadrant, primarily colon. So again, when we're percussing, we're going to primarily stick here. When we actually get to palpation, that's where we would go to all 4 quadrants. Now, you may hear people talk about 9 quadrants. And when they talk about that, they're talking about the epigastric area, the hypogastric area, the flank, the iliac fossa. I don't honestly see that in clinical practice as much. What I see in the documentation, what I hear, are the basic 4 quadrants. So if you remember those, you're going to be fine. When you're palpating each of those 4 quadrants, remember, just as with the head, ear, eyes, nose, and throat, you're going to start with light palpation, then go deep. The difference in the abdomen is we're going to add one more level. So light palpation, fine, deep palpation, and then rebound tenderness. Because when we talk about peritonitis or other fulminant infections or inflammatory processes in the abdomen, you can actually have pain on rebound or release of the pressure. So when we talk about the rebound phenomenon or rebound tenderness, that's what we're talking about. Again, thinking about the anatomy that's in each four of those quadrants guides your fingertips. One more time, the gallbladder or the liver with the gallbladder underneath it, stomach, the pancreas goes across the top, the spleen over here, I don't think I mentioned that the first time, and then the colon sort of all nestled in here, large intestine, small intestine, all nestled in below with the appendix in the right lower quadrant. Now, when we palpate the liver, different than the percussion, we found that lower edge by percussing it. Now what we're going to do is at that lower edge, we're actually going to try to hook our fingers. Please make sure you've cut your fingernails so that you're not digging into the patient, but you're going to try and hook the edge of the liver. You're not actually going to get underneath it because you don't have the flexibility of the fascia. But what you're trying to feel is as you go down, what does the edge of the liver feel like? Is it smooth? Is it fairly pliable? Do you feel nodules or firmness? Is it resistant to your fingers going around the edge of it? I will tell you that Catherine has a lovely pliable liver, which is demonstrating exactly what a normal liver should, a nice smooth edge. No nodules, no firmness, just like it should be. And certainly if the liver is enlarged or if it's tender, those are abnormal findings. Now, on the opposite side, I should probably mention at this point, by convention, when doing an abdominal exam, because so much of what we look at in the abdomen is on the right side, it is usual to find the practitioner on the right side of the patient. This may or may not be helpful to you if you are strongly left-handed or if you're trying to truly visualize in your mind what's happening on the left side of the body. So if at any time as I'm describing what I'm doing, if at any time you feel like you need to step around the opposite side of the patient and work from there, please feel free. The other reason I'm staying on the right is so that you can see what I'm doing, so that I'm not obscuring the film. On the opposite side of the abdomen, still in the upper quarter, but the left upper quarter, we find the spleen. Now the spleen is not as anterior as the liver. It lies in the mid-axillary line, so pretty much almost dead lateral, a little bit anterior to that. The interesting thing about the spleen, for a very good reason, is it's protected by the ribs, because that's where all the blood cells are formed and replaced and renewed. It tends to be protected. So it's not like you're going to be able, unless somebody has splenomegaly, it's not like you're going to be able to actually take your hand and feel the spleen. Here's how we can do it. You get your hand on the mid-axillary line, come a little forward, and then have the patient take a deep breath in. Perfect. And then relax. And what you'll do is you'll find a little firm organ moving into your fingertips. Again, you might find this easier if you stand on the left side of the patient so that you can actually cup the ribs with your left hand. Breathe in again. Good. And then relax. Remember that it's not going to be large, it's not going to be nearly as pliable as the liver, and you're really only going to be able to feel it in the normal patient on inspiration. When you do feel it, you're trying to feel if there's any tenderness, any rough edges, any nodules. Now, again, the gallbladder is pretty much covered by the liver, so you're not going to be able to directly palpate the gallbladder. So how do we incriminate or discover gallbladder or biliary pathology? We use what's called Murphy's sign. Again, here we are at the liver, and we've hooked the edge of it. Remember, we had the patient inhale for the spleen, and I showed you that first because that's usually not painful. Someone with gallbladder pathology, this is going to be painful. Hopefully, Catherine doesn't have any gallbladder pathology, but what you do is you have your fingers at the edge of the liver, have them inhale deeply, just like with the spleen. Go ahead and take a nice deep breath. And if they have focal pain, go ahead and relax, either under your fingertips, or if you get the gold ring on the carousel, if it reproduces their chief complaint, oh wow, I feel my shoulder pain. Wow, that made my right shoulder hurt. That's positive. That's the sign that there is gallbladder involvement. And again, we call it Murphy's sign. So it's simply hooking the liver like we did before, but adding a deep inspiration to put pressure directly on the gallbladder. Now let's move to some vascular examination. The descending aorta goes pretty much midline. It might be a little bit to the left of midline, but if you start at midline, you're going to be fine. What I tend to do is I tend to start at the umbilicus and then bisect the difference from the distance from the umbilicus to the xiphoid. So about right here, again, remember everyone's anatomy is different. Nobody has exactly the same, so this is just a rough estimate. But I'm going to take 2 fingers. I might take 2 fingers of the one hand, or I've also seen people take 2 fingers, one from each hand, and you're going to come slightly to the left of the umbilicus, and you're going to feel for a pulse. And she has a nice firm pulse. Good. This is going to be pretty deep. This is not a superficial pulse. So again, you want to make sure that you don't have somebody who already has a history of an aneurysm, that to your knowledge they have normal vasculature. Once you've found the pulse, then you start separating your fingertips. You just sort of go laterally until you feel that pulse go away. And then you measure the distance between your fingertips. 2 centimeters or less is what's normal. If it's significantly more than 2 centimeters, and remember, this is a gross test, so if it's 2.5, I wouldn't get as concerned. But if I'm out here, 4 or 5 or 6 centimeters and I'm still feeling a pulse, I'm going to call that patient's physician. To confirm, this is where I would actually bring back the auscultation. I'd pull out my stethoscope again, and I'd start listening for the aorta. And what you're listening for, if you're concerned about an aneurysm, is instead of a nice thump, thump, thump pulse, is you will actually hear almost a wave sound of a bruit or a bruit. I've heard it pronounced both ways, B-R-U-I-T, and it does sound like the waves on the seashore. Whoosh, whoosh. I cannot find a sound bite on the internet to share with you, but take my word for it. It doesn't sound like a pulse, it sounds more like a wave. And the reason it does that is because the blood is moving from a narrow channel to a larger area, and so you get that whoosh effect. You can not only auscultate the aorta while you're here, but you can go to the iliac arteries as well as the femoral arteries. So that's when you can introduce your vascular auscultation. In supine, you can still palpate the kidneys. Again, they're not as easily palpable. They're much like the spleen, but in a very, very thin client, you might be able to palpate the right kidney. The easiest way to do it is to, from the anterior approach, take your right hand and you're pressing down while your left hand is under the body, parallel to the 12th rib, and your fingertips are at the costovertebral angle. Catherine, tell me if this is painful.
Okay.
It should not be, but we are talking deep palpation. And what you're trying to feel is with either hand, the purpose of the left hand is to try and bring the organ up to your right hand, but you might even be able to feel it with the left hand depending on the patient's morphology. But what you're doing is you're feeling in there for any kind of firm organ. The kidney is a firm, solid organ. When we did the sitting test, we did not want to have any tenderness with palpation. Doing this test, we do not want any tenderness with, sitting test, we don't want any tenderness with percussion. With the supine test, we don't want any tenderness with palpation. So it's another assessment method for looking at the kidney. One of the big ticket items that we tend to think about is the possibility of appendicitis, or acute inflammation/infection of the appendix. So how do we find the appendix? Interestingly enough, in most people, it's in pretty much the same spot. The spot is called McBurney's point, named for Dr. McBurney, who figured it out, and it's so simple. It is halfway between the ASIS on the right and the umbilicus. So I take my hand, I find the midpoint of that hand span, and that's where the appendix is. Now, again, not everybody's morphology is exactly the same, but in general, it doesn't deviate very much at all. You're going to apply direct pressure to the appendix and then allow the rebound. And if the patient is tender on either direct deep pressure or rebound effect, that's an abnormal finding. A real clincher would be if you did that and it reproduced the low back pain that they were coming to see you about. So again, the gold ring you're looking for is if you do any of these abdominal tests, and not only do you get focal complaints of pain, but it reproduces the chief complaint. That would be a conclusive finding in my mind. Now, the patient may not have focal or localized appendicitis. It may be diffuse peritonitis. And the way we tell that is by Bloomberg sign, which is almost identical to how we assess the appendix, but you do it over all 4 quadrants of the abdomen. And if you think about the anatomy and the difference between appendicitis and peritonitis, it makes sense. Appendicitis, localized to a very small area of the colon. Peritonitis, by definition, widespread inflammation and infection of the entire peritoneal cavity. Now, you get that board-like, rigid abdomen that we talked about in lecture, and you will also have positive tenderness, not only to deep palpation, but on rebound. And if it's really, really positive, you're going to get it not only where you're pressing, but elsewhere in the abdomen, because it's all connected. It's a single sac. So say the patient comes in with let's make it easy, left low back pain, and as you're just doing deep palpation, oh yeah, I have left abdominal pain on deep palpation as well as that low back pain. Well, that makes sense. I'm palpating directly over it. But then I go to the left upper quadrant, oh my gosh, there's that left lower quadrant pain and left low back pain as well. It's referred because, not because I'm pressing on a nerve that refers it, but because it's all the same area. The entire peritoneal cavity is inflamed, so it's all going to produce the same kind of symptom. Now, conversely, you may have the patient where it hurts directly under your fingertips no matter where you're pressing. You can see that with irritation of the bowel, such as with irritable bowel syndrome or inflammatory bowel disease, and you can get localized, responsive kind of pain. But if you get that remote palpation response, then I start thinking about things that involve the entire abdominal cavity, such as peritonitis. Again, thinking about the anatomy: liver, spleen, gallbladder under the liver, pancreas across, stomach pretty much upper quadrant more off to the left, the bowel all through here, especially the appendix in the right lower quadrant. We're now going to move to sensory testing of the abdomen. A couple different ways to do this. The easiest way is if you've already got your reflex hammer from testing the reflexes on the lower extremity, you can also test the abdominal reflex. And that is, if you can imagine the superficial nerves that surround the umbilicus, you can draw a quick little line and you'll see the umbilicus move toward the quadrant. There you go. Let's try that again. Beautiful. It will move toward the quadrant you're testing. And you want to make sure that happens all 4 quadrants. You then want to test the motion of the spine. Let's add in the one test that I didn't include earlier, which is passive flexion of the neck. This is testing for the potential of meningitis or anything else that has a dural component to it. So this is a passive test. And normal would be painless. Abnormal would be pain either in the neck or especially radiating down the spine, potentially even into the extremities. You would then move to range of motion of the spine as a whole. Catherine, can you just please bend your knees one at a time? Good. And then you can take your hand, just so that you don't kill your patient, one knee at a time, knee to chest. Good. And then bring your head toward it so that you're sort of getting that yoga crunch. Go ahead and relax back down. If they don't have pain with this, that's a nice clearance test for the spine as a whole. The final thing you're going to do in supine is, second to the final thing, is testing the SI joint. The way I learned compression and distraction is, if you think about the SI joint being on that oblique axis, if you apply pressure to the ilia and you're abducting the ilia, anterior abduction means you're compressing the SI joint posteriorly. So SI compression, and then adducting the anterior ilia means you're distracting posteriorly. You could also test shear, where you're stabilizing one hemipelvis and applying a downward vertical pressure with the other. Same thing on the other side. So those are just some musculoskeletal techniques that we're importing into this part of our exam. Before we leave the abdomen, we need to talk about the neurovascular bundle that lies in the femoral triangle. There's a mnemonic, which is easy to remember. If you are moving towards your umbilicus or navel, that is the orientation of the neurovascular bundle. So the femoral nerve is lateral to the femoral artery, which is lateral to the femoral vein, which is lateral to the lymph nodes. So the lymph nodes are the most medial, then the vein, the artery, and the nerve. So what? So what means that if you're going to test lymph nodes in the femoral triangle, you're going to have to get up close and personal with your patient. So I always warn them ahead of time. I tell them, Catherine, I'm going to check your pulse down here. So it's just going to be here in the sort of inguinal area, your little femoral triangle. And once I found her pulse, and I find a nice pulse, then I tell her, the next thing I need to do is check your lymph nodes. And that gets a little bit more personal. So I'm not trying to be fresh, I'm just trying to find your lymph nodes, okay?
Okay.
And that's important to do, especially in today's day and age. I mean, don't expect that people are going to be happy about you checking down there. But if you're truly going to be assessing lymph nodes, you don't get there until you are almost at the pubic symphysis. So, and the difference in Catherine is about 2 centimeters. So you really can't be here, you know, off on the artery saying that you're checking the lymph nodes. This will be one of the things we'll probably cover on your practical exam. I want to make sure that you're truly assessing what you think you're assessing. So remember, navel, moving towards the navel or moving medially, nerve, artery, vein, lymph. Lymph is the most medial structure there is. So, we've done the pulses, we've done the abdominal exam, we've done the SI joint, we've done gross motion of the spine. By doing the gross motion of the spine, we've also started to clear the lower extremity, but we can just kick out the rest of it and be done with it. Clear the hip by adding in the rotation component. You can even check their hamstrings, which is part of the straight leg raise if you wanted to do it like that. Making sure that as you're clearing the hip, you do both the figure 4 and the piriformis test. You would then move down to the knee. You could do your knee ligamentous stress test if there's any concern there. Move down to the ankle, same thing. So think about it moving from top down to the bottom. The final thing that I would do if I had any kind of neurologic concerns is a Babinski test. I'm not going to show you that because you guys know how to do that. And finally, you're going to flip the patient over on their stomach. And trying to keep them comfortable. Yep. I always have them put a pillow under their knees. Catherine, do you need one under your chest?
No.
Okay. Beauty about the plinth is you've got their face where they can still breathe. If you don't have one of these nice plinths, do put a pillow under their chest so that they've got something to lie on. Once again, you're going to expose essentially from the PSIS to, I would say, roughly T8 to T10. So you don't have to expose everything, but just get a good view of the lumbar spine as well as the lower thoracic. And again, before touching the patient, we're going to start with observation. What does the spine look like grossly? Is there symmetry? Any unusual scoliosis? Anything like that? And then palpating the spine. I tend to palpate either side of the spinous processes, feeling along the transverse processes, segment by segment. And then I can also actually do segmental PA glides at that point if I wanted to. I could palpate for the kidney, but gravity is going to take it away from you, so it's really not beneficial to do it in this position. So moving on to the musculoskeletal components, I would have, before I left palpation, I could palpate into the paravertebral muscles. How much tone is there? Of course, is there any tenderness with palpation? Is there tenderness off to the flank? And if it is off in the flank, I would go back and check my abdominal exam if I did not have any findings to this point, just to be sure that I didn't miss something in supine. And then I would have the patient do a prone chin on their hands. So, Catherine, what I'm going to have you do is come up sort of onto your elbows and just put your chin in your hands like you're a kid watching Saturday morning cartoons. There you go. That's the first piece. And then can you do a press up where you put your hands and literally just, press your, she's got great range of motion. Go ahead and go back down. Just totally relax again. And then you can test knee flexion as well as hip extension. Nice little test there. If you wanted to test your plantar flexors against gravity without it being weight-bearing, this is the place that you could do it. Just have them plantar flex and then you try to vertically displace their heel. If you've not been taught that, that's a neat little test. Let's see it again. She's plantar flexing. Instead of pushing on the toe, vertically translate the heel, and that gives you a more reliable test of the gastrocsoleus. When you're doing all these tests, remember that in practicals, in real life, with any of your patients, you don't have to do them all. This is just the complete toolkit. But when you're choosing which tests to do, you need to make sure that you're choosing tests that not only prove or rule in the diagnosis you're thinking about, but you must also do tests that disprove or rule out other diagnoses. That's what we call differential diagnosis. If all you get is yes, 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 you haven't proven anything. You've got to show that you've disproved. I know that it's not liver pathology. I know that it's not kidney pathology because of X, Y, and Z. Until you can say that, you've not done differential diagnosis. Catherine, you can sit up for me. My assistant and I thank you for your attention, and we wish you well in your practicals.